Welcome everyone to today's webinar. I'm Morgan Hafner with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Jay Levine is Senior Vice President and Associate Chief Medical Officer for Spectrum Health, a $5 billion not-for-profit integrated health system based in West Michigan. In his role, Jay provides leadership and oversight of care management, MedNow services, and the continued development of its clinically integrated network. Previously, Jay was the Chief Medical Officer for Priority Health, which is Spectrum Health's nationally recognized not-for-profit health benefits company that focuses on improving the health and lives of its members across the state of Michigan. Jay served on the board of directors for the Grand Rapids African American Health Institute and was a founding member of Project Access, an organization dedicated to providing healthcare services to uninsured, low-income residents of Kent County. He also serves on the Spectrum Health Continuing Care Board of Directors. Kent Bodsford serves as Navi Health's Chief Medical Officer. Ken has over 23 years of experience in internal medicine and infectious diseases, and has served in numerous consulting and medical director roles, as well as Chief of Staff for a hospital. Prior to joining Navi Health, Ken served as the Chief Medical Officer at Health Spring Incorporated for Alabama, Southern Mississippi, and Northern Florida. In addition, he also co-founded an independent practice association and an electronic medical records company. Dr. Bodsford, I'll now turn the floor over to you.
Great. Thank you very much. Welcome, everybody. We appreciate you joining us today. I wanted to just briefly go over some of the questions that we hope to address over the course of the next hour with you, and hopefully then leave plenty of time for you to ask any questions. So we're going to address why is care coordination more critical than ever for health systems now in 2017? What are the elements of a successful care coordination program? Dr. Levine is with us to help spotlight on a best practice that he and his team at Spectrum Health in Michigan have done. And then finally, what steps can you as healthcare providers take to improve your transitions of care at your health system? Next slide. So why, the first question, why is care coordination more critical than ever in this time of year, or this year? Next slide, please. As most of you know, in 2015 in January, HHS had this really pretty historic announcement where they set clear goals and timelines for shifting Medicare reimbursement from simply volume to value. As you know, in the traditional fee-for-service world, everyone got paid for ringing the bell, not how well you rang the bell. So for the first time, they had put out clear guidelines, time guidelines, to get into this alternative payment models and value-based payments. Next slide, please. So this is really where we were and where HHS wanted us to be getting. 2014, prior to this announcement, about 20% of payments were just, this is from CMS, were just traditional fee-for-service payments. About 60% were fee-for-service with some link to quality, whether it was a readmission penalty or upside, value-based purchasing, and about 20% were in alternative payment models, either bundled payments, ACOs, et cetera. And it was this top group, the alternative payment models, that CMS and HHS were driving to increase. In 2016, so the first year after this announcement took place, you see that they had already increased the alternative payment models by 50%, from 20% to 30%. Fee-for-service with a link to quality had gone down 5 percentage points, and traditional fee-for-service had gone down 25%, or 5 percentage points. And then their target was by next year, 2018, that fully half of Medicare payments would be based on an alternative payment model. 40% would be fee-for-service with some link to quality, and only about 10% in the traditional fee-for-service payment. Some of you may have been at the AHIP meeting this past fall in Washington, but all of the CMS leaders were there. Andy Slavitt, who was the former acting administrator, and Sean Kavanaugh, who was the deputy director for CMS, and they made several things very clear. Number one, we're actually ahead of that schedule that they laid out. And number two, that this was pre the election, I will add, but they felt that things were so far down the road in this movement that no matter which administration came into power, that this would really still continue. And we can talk about later during the question and answers maybe, but I think that I would agree with that. Next slide, please. So this is really talking about where our systems now in getting towards being able to live in this value-based care world. And this, to me, this slide is a bit of a, is the glass half full or is the glass half empty? As I say at the top, 80% of health systems are in the process of evaluating value-based care efforts. And this was the result of a survey of health plans. And as you see, 80%, as I said, are somewhere in the range between not pursuing to fully rolling out or nearly complete. But so that's the glass half full. The glass half empty is of that 80%, 60%, so 3/4, are very, very early process, either just investigating how they would deal in this future world or have a pilot underway. So that is to me the most surprising thing, and maybe it's just because I live in this world, but that 60% of hospital systems are at very, very early stage of learning about and getting toward this value-based care model. So let me go on to the next slide, please. So this is, I think, a really critical thing for everyone to understand, and that is as a provider takes on more financial risk, there is an increased need for them to do care coordination. So, you know, over on the left, the traditional fee-for-service, think of traditional Medicare, the hospital system, other than managing to their DRG, or the physician, other than be caring for the best outcomes of their patient, there's really no incentive to coordinate care. If you get paid for ringing the bell as often as you can ring it, then you have no incentive to worry about what happens after the patient is discharged, other than because it's, you know, the right thing to do. But other than that, there's no financial incentive whatsoever. Then as we move along the spectrum, pay per performance, as was mentioned in the introduction, I was the chief medical officer for one of the HealthSpring plans, which is a Medicare Advantage plan that now is owned by Cigna, and we had to pay for performance. So just some upside for physicians that if they met certain parameters, there were certain bonuses. No downside, so they weren't taking on a lot of involvement in care coordination, but there was some. Then moving a little farther towards taking more risk, the one-sided shared savings, meaning there's no downside risk. So you have some attention to the provider, again, whether it's a system or a physician, because there are potential payments for better outcome, but there's no downside risk. So you're still not really involved. And I won't, you know, bore you going all the way through BPCI, the bundle payment program that CMS has out. There they are taking risk and have the downside and upside risk in most of the models. So they're care coordinating, but only for a certain segment that they're managing in. Then the two-sided shared saving models where there is upside and downside risk. Well, now if a provider has the downside risk also, there's probably greater upside advantage because they're willing to take on the downside risk. But now you're really starting to say, wait, I really need to coordinate this care. I care if this patient is readmitted because that's coming out of our potential bonuses. And then moving over towards the partial capitation, where physician groups is maybe the example there, where they are taking on the capitation for a certain element of the care healthcare model with the ones that they can manage. And then all the way to global capitation, where Medicare Advantage plan would maybe be the example there. Well, they take on the full risk from Medicare for fee-for-service Medicare patients who sign up to get their Medicare through a Medicare Advantage plan. So on the left, you don't really care other than because it's the right thing to do what happens to the patient maybe after they're discharged from your facility, all the way over to the right where you absolutely care about everything. The physician might keep a slot open or 2 slots open in his or her schedule for the day, so that if somebody calls in and is sick, if you have no slots, you send them to the emergency room. Well, if you are going to be paying that bill and knowing that winding up in the emergency room has a significant risk of being admitted to the acute facility, and you're paying that bill, then you might be willing to keep 1 or 2 slots open on your schedule to make sure that you can see those people who really aren't emergencies but who need to be seen. Jay, do you want to make any comments around that?
Yeah, Ken, thanks. In our system, we've been in pay for performance risk for quite some time. In fact, the managed care organizations in Michigan have had a robust pay for performance program that has been slowly over time increasing our financial risk, especially when it comes to the medical home, patient-centered medical home initiatives. And one critical piece of that that we found is that we need more and more care coordination at the point of care. In fact, there's a lot of different definitions around care coordination, but one of the most essential pieces of care coordination is that care transition, the transition from the inpatient setting, back into the ambulatory setting or inpatient setting to a post-acute care setting and then back into ambulatory. So this has been driven in some ways, at least in Michigan, around certain metrics. So there was a metric around primary care follow-up within 7 days of a hospital discharge. That was kind of our first exposure to really concentrating on that care transition. If you go to the next slide, the care transition is like such a critical piece when you're managing clinical risk that, to execute on your increasing financial risk. So I have a story around care transitions, Ken, and it's many years ago I was given 2 tasks at home here in Grand Rapids, Michigan, and one was to rake the leaves in my yard, and the second task was to watch my dog Dutch. This is my dog Dutch. Well, the first task, I was a success. I got the leaves raked. The second task, I failed. I didn't watch Dutch very well. He actually ran into the street and he got hit by a car. So I went out to examine him, and being trained as a general surgeon and a trauma surgeon, I picked him up, did my full assessment. My family, I have 4 girls and 1 boy. They came, when I was raking the leaves, they were nowhere to be seen, but they came out and were crowded around wondering what happened to Dutch. Well, he had a small laceration on his chest. So again, being a surgeon, I said, well, maybe I'll just clear off the kitchen table and we'll fix him right here. That wasn't going to fly in our house, so I was overruled, and we ended up taking Dutch to our local vet at Cascade Animal Hospital. When I got there, he had to stay overnight and get his wound closed. Came back the next day, Ken, and here's the critical point. I was in a hurry. I wanted to get Dutch out of the hospital, but the vet sat down with me, literally would not let me take Dutch home until I went through about 45 minutes of a discussion about how to take care of Dutch when he came home with me. And the vet was very critically evaluating if I knew what was supposed to be done and knew all of the proper wound care and all of the other necessary things, what to look for if things weren't going right. And then I was allowed to take Dutch home. So I contrasted that with, I went into the hospital to do my rounds later that day, and I discharged 7 patients in 30 minutes. That told me right there, we have a care transitions issue. And it's not an issue where one person isn't doing something that just needs to be changed. It's actually a systemic problem. And much of this is driven because that transition between inpatient and outpatient has always been siloed. And it got me thinking around, boy, we really do need a systemic solution, something that completely changes the way we do our work. And that was an eye-opener for me as I was thinking about how value-based care might be one of the ways that we can start to get better into the care transitions world. So I just wanted to share that with you, Ken.
Thanks, Jay. I've heard Jay tell that story before and asked him to tell it again today. And to me, it absolutely epitomizes a major part or explanation for why we have the problems that we do. And guilty as charged, as Morgan said in the introduction, I practiced internal medicine and infectious diseases for 23 years and was busier than I probably should have been. And I shudder to think of the real discharge planning that I was involved in discharging all of my patients. So I think it's just a great story and a great reminder to any of us who are either physicians involved in discharge planning or health systems who are involved in discharge planning that we just have got to take more time and walk through it and make sure patients really understand it. And that's really what we're going to be getting into more in detail in the rest of the presentation. So could I have the next slide, please? Great. Well, clearly there are many challenges, of course, in care coordination, but I think 2 of the major ones are these 2, medication management and managing the care transitions. As you see, about 30% of patients have at least one medication discrepancy upon discharge to the hospital, from the hospital. Different than what the hospital thinks they went home on compared to what the patient thinks they went home on. About 1 in 5 patients experienced some adverse event within 3 weeks of discharge, and 60% of these were medication related. So a very significant percent of patients have problems that are related to medication management, either errors or omissions. And then on the care transition side, about $100 billion is spent annually in post-acute care. And by post-acute care, the way we define that is skilled nursing facilities, inpatient rehab, long-term acute care, home health, and readmission. The wrong first pack setting, both our data at NavHealth and others have confirmed this, that the wrong first pack setting actually increases readmission rates. I, as a provider, always assumed that the higher level of care would be the safer place to send somebody. That is not necessarily the case at all. And the same thing with the length of stay. People think that, well, a longer length of stay at a post-acute facility is probably better. If it's short, we're just trying to send people home too soon. But that is not true. Longer length of stay increases the risk of falls for patients, increases their risk of exposure to C. diff, et cetera. Post-acute care is utilized, as we'll talk about, by almost 50% of Medicare patients. When they're discharged from the hospital, will utilize one of those settings that I just talked about. The other thing about post-acute care utilization that is really fascinating is that about 73% of the variance in Medicare spending is driven by the utilization in post-acute care. So let me explain what I mean by that. Several years ago, the NIH came out with a big study, and they had been looking, the idea of the study, the goal was to identify what was driving the geographic variance in Medicare spend per beneficiary. Rochester, New York had some of the lowest spend per Medicare beneficiary. Miami-Dade area had some of the highest spend. And when they looked at the various drivers of that variance, I think to most people's surprise, certainly to my surprise, 73% of that variance was driven by the variance in post-acute care utilization. So the people in Rochester had much lower post-acute utilization than the people in Miami-Dade, but there was absolutely no difference in the quality of the outcomes. So when they normalized the post-acute utilization across all geographies, Rochester and Miami included, 73% of the overall variation went away. So that was really one of the big studies. We at NaviHealth had been preaching this for a while, but that was one of the big studies that really got everybody's attention, that was part of the problem. This spend, the variance in spending and the inconsistency was driving a huge part of the spending variation from Medicare. And as you see, readmissions cost the healthcare system about $30 to $40 billion annually. Next slide, please. So let's transition to the second question that we hope to address for you today. What are the elements of a successful care coordination program? Next slide. We've talked about some of these a little bit already, the medication management and the care transitions. Think the right care, right place, right time. It's sort of a cliche phrase. A lot of people use it. I think it's probably overused. But I think for these two areas, it really is appropriate. Ensuring that patients understand their doctor's orders and medication instructions. There was a study last year that showed fully 50% of patients do not understand and come away with a different opinion of what their doctor just told them as they're being discharged. The right place, medication reconciliation, is key. It's now a CMS star measure, but to me, it seems that the medication reconciliation is very inconsistent in how people do it and what's done, and it is critical, again, to manage the transitions of care. In the right time, missed medication doses alone can account to 10 to 25% of all hospital and nursing home admissions. So just missing several doses in a very tenuous patient can result in a very significant risk of readmission or transition to post-acute care. And on the care transition side, addressing the patient-centered discharge planning by risk and what the patient's condition is and ability to self-manage, I think, is key. Most of you, I'm sure, are familiar with Dr. Eric Coleman from Colorado. Eric is sort of the father of the care transition coaching program. And I've heard Eric just say 1,000 times at talks and in working with us that if the patient don't understand how to manage themselves, you're way behind the 8 ball. We cannot have home health in the home with patients 100% of the time. 99.9% of the time, the patient and or their family are going to be there, and they have got to understand how to self-manage. We can't totally rely on home health because they're not going to be there, but a very, very small percent of the time. And then for the transition, choosing the right setting and practicing warm handoffs. Numerous studies have been done to show that if there's a warm handoff from the acute to the nursing staff or physician to physician from acute to skilled nursing, say, that there are vastly improved outcomes. There is already knowledge of what medications is the patient on, what are their limitations, what are the patient's expectations, really, really key. And that first pack setting is so important. A lot of people, as I said earlier, I always assumed when I was in practice, well, the higher intensity setting has got to be the safest. But that's not necessarily the case. The higher setting, actually, the best outcomes may be at a lower level of care. But the flip side is not true either. A lower level of care is not always the cheapest. If you send somebody home health who should have gone to a SNF and they result in a readmission, that's more costly than it would have been. So I think the key to approach is the patient needs the right care. And even if that setting is more expensive than some of the alternatives, if that's the care they need, that's where they need to go. And at the end of the day, they will have better outcomes and therefore better financial results. And then the variation in discharge planning leads to poor transitions, lower patient satisfaction, and ultimately readmissions. There is a huge variation, just like in the amount of post-acute care utilization, as I talked about previously, huge variation in how we do discharge planning. Next slide, please. So in this, I just wanted to talk about briefly about how a high-performing network is essential. We'll talk about that more a little bit later. And I don't want anyone to think that I am implying here that we should be making clinical decisions based on financial decisions. As we said earlier, about 50% of patients will go to some form of post-acute care, home health, SNF, inpatient rehab, long-term acute care. And you see the average expenses for those. And again, I'm not by any means suggesting that any physician or any hospital should, the cost of the next setting should drive their decision, but I think it is appropriate that we all do understand what the financial implications are as we're making these decisions. And the only number that I would question a little bit here is you see the average SNF cost per episode we have listed as $19,000. That's from MedPAC data, which is really largely fee-for-service, unmanaged patients, so some very long stays in there in unmanaged areas. Our data at NavHealth really suggests where we are dealing primarily with managed care patients, Medicare Advantage patients. Our average SNF day is about average SNF stay is about $10,000. So that's the only thing that I would say. We see slightly different numbers in our population than we have listed there. Next slide, please. So now we're going to transition over to what Jay and his team at Spectrum have done as a best practice spotlight. So Jay, I'll turn it over to you.
Okay, thanks, Ken. So I'd like to go to the next slide and just introduce the Spectrum Health system and how we came to partner with NaviHealth. So Spectrum Health system has a hospital group, 12 hospitals, a physician group of about 1,400 employed physicians and APPs. Then we also have a 750,000 member Priority Health plan. And in that health plan, we have Priority Health Medicare Advantage, about 120,000 covered lives. And in West Michigan, where Spectrum Health is located, our Medicare Advantage penetration is about 50%. Traditional Medicare is about 50%. Of the Medicare Advantage population, Priority Health has about 70% of the market. The health system, Spectrum Health, has about 50% of those admissions that are Priority Health admissions to their facility for Medicare Advantage. And then the Spectrum Health system itself in the Kent County region has a market share of about 63%, and in the 13 county area, the hospital market share is 53%. So that's a little bit about the environment that we were working with in Spectrum Health. Ken, I don't know if you have a couple comments about NaviHealth.
Yeah, we just to tell you a little bit about NaviHealth. We were formed about 5 years ago. In doing that, we bought a company called Senior Metrics, which some of you may be familiar with. They had developed a functional assessment tool about 15 years ago to manage patients through post-acute care. And then in August of 2015, NaviHealth was acquired by Cardinal Health, so we're now part of the Fortune 21 largest company. Then since Cardinal acquired NaviHealth, we have acquired two companies that we thought were fitting into helping us manage patients through the post-acute transition. And those two companies are Right Care and CuraSpan. So as a result of what NaviHealth had done and then being combined with Right Care and CuraSpan, we now manage over 20% of the discharges from an acute care setting across the country. We have over 2 million Medicare Advantage lives where we are managing all or part of their post-acute care. We have clinical services and over 48 states, connected to very many hospitals and very many post-acute providers. So we have had a lot of growth and have had a great partnership with Spectrum Health as one of our earliest Medicare Advantage plan partners.
Okay, so just a couple comments about the post-acute environment around West Michigan. So our skilled nursing facility, Priority Health, participated in a very wide network. We had like 270 facilities, actually statewide. Our top 20 facilities, we had about 50 to 55% of our hospital discharges went to the top 20 skilled nursing facilities. And interestingly, Spectrum Health owned 2 of those facilities, and we also had for-profit skilled nursing facility providers and not-for-profit providers. The payment mechanism for skilled nursing facilities, that was largely per diem. We did require prior authorization, and we did not have a 3-day, required stay. We could actually admit even directly to a skilled nursing facility. And we had the usual Medicare benefit design for Priority Health Medicare Advantage. So I want to spend a couple of minutes just describing the problem we were trying to solve. Then I'll go into how we worked with Navi Health with a data-driven solution that really, how the partnership helped us to drive to results. And then I'll show you our results and some of our next steps. So we had already had in place telephonic case management, RN case management, prior authorization, and medical director review for our skilled nursing post-acute care. Even with that, we saw, a huge variation in care in our skilled nursing facility network. This came out in a whole variety of ways. There were times where we saw frail elderly patients in skilled nursing facilities that really had not had any progress for a week or even more, and they were not appropriately discharged in a timely fashion, but we really didn't have any way of measuring that. And then we would have healthy people, a post-op total joint or a post-op spinal fusion, who were ready to go home, and our nurse care managers were trying to move them along, and there seemed to be inertia in some, but not all, but some of the skilled nursing facilities. And this variation in care was quite troubling, and we were looking for solutions to this. How could we quantify this better? The other thing we saw was that there was a significant variation in the medical spend. Our SNF days per thousand were increasing exponentially, and much of that was driven by the pressures on acute care hospitals trying to maximize their DRG in some ways, and then discharging to a post-acute care setting. So this was part of the issue, and frankly, when we were speaking with our different skilled nursing facility providers, there was always this question about, well, I'm taking patients that are more difficult. I'm taking sicker patients. I'm going to be your partner by taking the complex ones, whereas some of the other ones you're measuring aren't complex. Our blunt measurements of, just average length of stay that wasn't risk adjusted, or our readmission rate, really couldn't account for this issue around, is there a facility that actually is doing a better job with complex patients? We just didn't have a way of measuring that. And then when we looked at nursinghomecompare.gov, we really didn't find that useful whatsoever. What we really desired was an objective benchmark that could measure rehab improvement and efficiency of care, and set benchmarks that we could risk adjust to the population that was being served at each of the facilities, and even at an individual level. Is this patient meeting a benchmark? We wanted to be able to compare how SNFs were doing, or how the skilled nursing facilities subacute rehab were doing if you compared them to other facilities. We didn't have a good measure for that. And then we wanted to be able to take this information and then give feedback to our discharge planners. We actually call them now care transition specialists, to show them how did your patients do once they left the hospital. And this would be very valuable information that could lead to continuous performance improvement and give them, the personal, professional satisfaction about, yes, my patients are being cared for in a high-performing facility. And I have a lot of confidence when I recommend that facility. So the solution we came to was a comprehensive RN care management transition program that went from a telephonic model to boots on the ground in the acute care facility to start, and also in the skilled nursing facility, working with our top volume skilled nursing facilities. The other component to our solution was the Navi Health Live Safe data-driven tool. And so if you go to the next slide, I'd like to address how this data-driven approach really made a difference in what we could show to our skilled nursing facilities, but also how we could then measure, improvement. So in this approach, every patient who is likely to get to a post-acute care setting as the next setting of care, whether it be home health care or a skilled nursing facility, would go through the Live Safe. And the care manager who's in the hospital would message the tool, the information is saying, this might be your best option. Taking into account other factors that that patient would have, it would still be, it's not a rule, right? It's a guide, but it would give them a data-driven approach, and then it would actually be able to tell them what to expect when they got to the next level of care. If they went to a skilled nursing facility for subacute rehab, they could expect to be out in, let's say, 15 days, and could start talking to the family, let's get ready for improvement so that they can transition to home at the appropriate time. This was very important. It actually helped our health system because patients felt very comfortable that, oh, this is what I can expect when I go to a skilled nursing facility. Then we had RN care managers who were in the facility working with the team, the rehab team. We would do the same Live Safe tool, re-emphasize what they learned in the hospital. It actually gave patients and families confidence that, hey, we're on the same page here. Here's your goal for, becoming independent again. We're going to quantitate that. This quantitative score helps us to know when you're ready to go home, and we're going to be proactive in that approach. So that comprehensive care management team with a robust tool that can measure was the backbone of our management program. Very interesting, when we started this journey, our SNF days per thousand, as you can see, was 966. And as Ken was describing, we know that in a unmanaged population, that can be as high as 2,000 days per thousand. In fact, across the state, in Michigan, there's actually a few counties that are in that, that degree of utilization. Even with a SNF days per thousand of 966, we were able to reduce that significantly, and at the same time be proactive and be able to monitor how well their rehab was going so that they are being appropriately discharged at the right time. When the care managers are there side by side, it actually gives patients a lot of comfort that I am now ready, and then they can also hand it off back to their medical home in the ambulatory care So we work with our own doctors and other doctors that are in primary care to transition them back into ambulatory care. So as you can see, we saw some very good reduction in the average length of stay, very good reduction in the SNP days per thousand for the entire population, and this was all risk stratified. So if you go to the next slide, one of the benefits that we had is now we were able to see what facilities are hitting their benchmark and what facilities are not hitting their benchmark, both in the discharge score, which is the rehab score, and in the therapy hours, and in their readmission rate, as well as their length of stay. So when we brought together our best performers, we were able to see that there's a significant difference in the high-performing group than in the non-consortium facilities. This is a continual improvement process, and actually we've been able to show that many of our facilities are competing against each other to do better, because our health system and our health plan are looking to make sure that they get the highest volume of patients. So I think this, Ken, is our results, and where we're going from here is to have a continuous work group to help to improve the management of patients that are in the transition. I'll turn it back to you.
Thanks, that's great. We, as I know all of you can tell just by hearing Jay so articulately address this, they, as he said, started out already with a low still nursing utilization, and Jay just took the approach that, yeah, that's good, but we can be better. And Jay, remind us, you are now a 4.5-star plan or a 5?
Yes, so our Medicare Advantage plan has been 4.5 for 4 years. Our overall readmission rate is around 9%. And in fact, in this program, Ken, we did not see any increase in readmissions. In our consortium facilities, there was actually a decrease in the 30 and 90-day readmission rate.
That's fantastic, thanks. Okay, so now we'll quickly address just the last few slides and then get to some of the questions that I hope we have generated in the discussion. So what steps can you take to improve your transitions of care at your health system? Next slide, please. And just talk a little bit about what a best practice program looks like. And you just heard from Jay what clearly a best practice program looks like and what it does. But a few things, the right care, we talked about the right care, the right place, the right time. The right care, what it's not is just having a case manager to oversee the discharge. And you all from health systems are well aware of this. There are thousands of openings for discharge planners and case managers across the country. They're under tremendous pressure to get people out, to maximize the DRG and open up a bed for that next patient. And it's got to be a more multidisciplined team to manage that, as we'll talk a little bit on the next slide. It is assuming ownership of the patient before, during, and after an inpatient stay. Again, as we talked about, whatever comes out of the bundle payment for care improvement program, it is not inconceivable that hospitals would be given the risk for that, and they've got to know exactly where patients are going, what the readmission rates are, et cetera. The right place, what it's not is simply handing a patient and family a directory of available post-acute facilities. Yes, clearly we realize the patients have got to have choice. CMS is very clear on that. But just like when patients would ask me all the time in practice and ask Jay in practice, well, what doctor would you send your wife to? What doctor would you send your mother to? You can talk about the facilities that you have relationships with that you think have quality outcomes, but it's still clearly their choice to go to whatever facility is in your network if you have a limited network or in your area. But I think the real key for you to be able to make intelligent decisions along that is to have a technology that really helps identify the patient's outcomes. You've got to know what the readmission rates are and average length of stay for your facilities to really know where you're sending people and that you're sending them to the right right setting. How much functional gain are they getting? And as Jay mentioned, it's all got to be case mix adjusted. And again, the right time. You can't just assume that if you have an ACO that they're really taking care of all of your patients, because as you know, the attribution is not always straightforward, and you can't just assume that that's going to take place. And as Jay just mentioned, a strong network based on real outcomes data, not just length of stay, because every facility says they get the sickest patients, and that's why they have a longer length of stay. So you've got to be able to case mix adjust it so that you know exactly where, what facilities are giving your patients the best outcomes. Next slide, please. And so then finally, how do you get started? Well, you have to establish, as I said, a multidisciplinary planning team. It needs to include people from pharmacy. It needs to include people from IT, patient navigators, everybody, to make sure that, as we talked about earlier in the presentation, medication reconciliation and care transitions are being taken care of so we don't wind up with readmissions. Using technology to support informed decisions. You've got to have the data to really know that the right setting that you're sending patients to. And then finally, building a high-quality post-acute network, as we've talked a little bit about. You really have to partner with somebody, because I think in almost every setting that we've experienced, a hospital really doesn't have this data. So you have to know, when you're sending people to a post-acute facility, what are their readmission rates? What's their average length of stay? How much quantitatively, how much functional gain did they get? And again, it's all got to be case mix adjusted, because otherwise you may look at just the diagnosis and length of stay, which is really all you have, unless you are partnered with people who can bring that data to you. And you might assume that a facility with a shorter length of stay is the best quality outcomes, when in fact they may be the facility that's just taking your knees and hips. So you have to have the data around that to really know true quality outcomes, not just star measures from CMS and length of stay, et cetera. Next slide, please. Okay, so finally, we hope that you've learned a bit from this presentation, in particular the medication therapy management and care transitions. If you'd like to learn more about that, we at Cardinal Health be very happy to work with you on that. You see the email there on your slide, the care transitions at cardinalhealth.com. Please feel free and be happy to reach out to that. We would be happy to work with you and discuss with you any thoughts we have around issues that you're having, or how you can improve your value-based care initiative. Next slide, please. And so, Morgan, I think I'll turn it back over to you for questions. Is that correct?
Yeah, that is correct. Thank you so much, Dr. Labine and Dr. Bolsford, for that fantastic presentation. We will now begin today's question and answer session, so please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. And it looks like our first question is coming through from the audience. So during your presentation, you mentioned key steps to take as you start a transition of care program. What if you have one that is operating now, yet needs to be improved upon? Are there different best practices for improving an existing program?
Morgan, this is Ken. I'll give a shot at that, and then Jay, feel free to jump in. I think the key to that is really having a good feel for what you're doing well in your care transition program and what you aren't doing well. So this may be obvious, but you have to have a sense for that. And what you are doing well, don't change it. And any holes or gaps that you have in your care transition program, that's where you've got to fill and improve. So if you, for example, just have a discharge planning involved in the discharge, and the discharge planner is basically simply taking the recommendation of your physical therapist, who all are good, well-trained, care about the patients, but you've got to have more people at the table to help address that. So I think that's the key, is really knowing what you're doing well, knowing what you're not doing well, and try to fill those gaps where you're not doing well.
Ken, I'll just add to that if you have a care transitions program right now, but you struggle with quantifying, how well you're doing in care transitions, or you struggle with not having good data that can reliably show the impact, you may want to consider looking around for how to quantitate what you're doing, so that you have the ability to have a data-driven approach.
Great. Thank you so much, Jay, for clarifying that, and Ken as well. And we have another question. With all of the change and noise out there right now in healthcare, getting our executive team to focus and invest in transitions of care can be difficult. How should a hospital or health system go about putting a compelling case together for implementing or enhancing a transition of care program?
And so, Morgan, I'll take that. So transitions of care program is valuable in many ways, even if you're not in a value-based contract. Lots of health systems struggle with, what's my top priority, and the discerning, all the competing priorities. But certainly, as you start to build your capabilities to manage care, manage the clinical risk, because you know that you're going to be under some financial risk, that this care transition should be elevated towards the top of your list of priorities, knowing that you need to build this for the future. And even if you're currently not in value-based care, this competency around managing the transition as well as managing medication management, that can help you in current DRG performance, because you're decreasing variations in care, even in the inpatient state.
That's a really great point. Thank you for clarifying that. And we have a question from the audience. What role does EMR play with your multifaceted health system coordination? Or in other words, do you use the same EMR?
So I can comment on that. We're actually in the middle of a transition. We're going to one EMR. We're going to use Epic both for the ambulatory and the inpatient. And certainly, if you're fortunate enough to be, on a single EMR, you may be ahead of the game in how you are able to transfer this information. I'll just say that I don't think that is mandatory, that the data-driven approach can actually, you can feed that information to your care management team, and in the comprehensive care management approach, you can show the data that is provided by the NaviHealth LiveSafe tool, and you can just bring it to your skilled nursing facilities, show them the information, and show them what they need to get to for their benchmark, and show care management, because that care management activities is really what's going to drive the results.
Great, thank you for that great question and informative response. The next question coming in from the audience is, do you experiment with having a single care manager follow selected patients across the continuum?
Jay, I can give a little bit of example of that, and then you can talk about how you address it. At NaviHealth, we are not at risk for readmissions with our Medicare Advantage partners, although we track it very carefully, because we will have accomplished nothing if we improve utilization at the expense of higher readmissions and poorer patient outcomes. We'd all go back to doing what we were doing before starting the company. So but on the BPCI side, the bundle payment for care improvement, where we are the convener with CMS and we partner with large health systems across the country for our acute care partner, we do have care managers who manage and keep in contact with those patients over the course of the 90-day post-acute episode. We've done a lot of work over the years, a lot of work at at looking into the benefits of having people in the home versus telephonic. And I'll be honest, our data is still a little conflicted on that as to whether we really gain a lot by sending people into the home. We originally had all of our care managers go through Dr. Coleman's care transition coaching program. So we do experiment, don't experiment, we do use a care manager following them on the BPCI side. Jay, I don't know if you have any comments about how you handle that.
Yeah, so in our kind of spirit of continuous improvement, we did not have a care manager who followed selected patients through the episode in post-acute and then for 60 or 90 days. But what we are implementing we're doing two things. The first thing is we want to risk stratify the inpatients to see who is at the top of the risk strata, like the most complex people. And then we have developed a role we call a transition coach, very similar to what you were saying, Ken. And that transition coach will meet the patient and the inpatient, will follow during the post-acute stay, whether it be in a skilled nursing facility or with a home health care nurse, and then for an episode of 90 days, stay with that patient to be able to guide them both in their ambulatory visits as well as continued home health visits because they are stratified into the most complex patients.
Great, thank you so much for that very informative response again. And it looks like we have time for one more question. And so with data and discussion on care transition for the patient who may be known as or expected to be adherence risk, what have you seen? Is there a way to involve the patient in the risk?
Wow, that's a good one. I don't have a real good answer for that, Jay. Hopefully you do. I think the medication therapy management programs that I know Cardinal Health has in place and other entities, I think, really try to get at that. Educational programs to make sure that patients and engaging their family wherever you can to make sure that they understand the ramifications of not taking medications, not getting them filled, making sure that they weren't on a generic of Coumadin and now they're given a prescription for brand Coumadin and they're taking both. But that is a very, very tough problem to address that you have asked about. Jay, have you all addressed that in any?
Well, it's interesting, Ken. So involving the patient, what we've tried to do in our stratification process is overlay our clinical risk with is this patient an engaged patient who is very interested in self-management, or is it a disengaged patient who might have some behavioral health or psychosocial issues that prevent that person from being engaged in self-management? And then we try to dedicate more resources to patients who we are not confident that they're engaged. So we're experimenting with, that type of stratification to see if we can have an impact.
Thank you both for pointing that out. And that is all the time we have for today. I want to thank Dr. Labine and Dr. Boltzford for their excellent presentation and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.